so many of the patients are females of childbearing age. So I'm just going to consider 3 points this afternoon. Firstly, what factors affect fertility after transplant? What considerations are specific to patients with autoimmune diseases? And then what data exists for patients with autoimmune diseases? So the 3 main factors affecting fertility are radiation, chemotherapy and age. In this study you can see that so this line here is the patients that have had chemotherapy only, and you can see that by a couple of years after transplant, more than 60% of the patients will have evidence of gonadal dysfunction. But what is also very striking is that if you've had fractionated radiation, your chance of infertility approaches almost 100%. And this data shows very similar findings. These are patients who've had sperm samples taken after transplant, and the normal patients are in this blue colour. You can see after total body irradiation, very few female patients will produce sperm in a normal way. After chemotherapy, it might be a lot more, but this is still not great. It's less than a quarter of the patients that are producing normal sperm counts. We know that radiation is potentially sterilising in men, and the higher the dose, the greater the chance of infertility. There is a suggestion that in patients who don't have graft versus host disease, who are young at the time of the transplant, that's the patients all below here, that if you follow them up long enough, there may be some recovery of sperm, but you're not going to rely on that. You're definitely going to want to store sperm on patients beforehand. In female patients, the situation's slightly different because we produce all our germ cells before birth. And we actually have our maximum germ cells at month 5. By the time we're born, we've already lost 4 million eggs. And by the time we hit puberty, we've only got about 40,000 left. And what's interesting is that chemotherapy and radiation will both accelerate this physiological apoptosis, and that's how we lose our eggs after these modalities. And so the sterilising dose is going to depend on age. So if you've got a young child, they may need 20 gray or more to kill off all the eggs, whereas if you're elderly over the age of 20, you might only need 16 gray to kill them all off. And our radiation biologists have done various mathematical calculations that enable us to actually look at the age at which you might have an early menopause. So if we look at an 18-year-old girl who has 12 gray, for example, as a transplant, then her predicted age of menopause is about 20. And that's really to make the point that just because somebody appears to be menstruating normally after transplant, it doesn't mean they haven't had a lot of gonadal damage. That's absolutely inevitable, and the patients will undergo a premature menopause. The agents that we use is, of course, very important. In this analysis, you can see that alkylating agents were the worst culprit causing infertility. And it's also important to remember that combinations of drugs can prove to be particularly gonatotoxic. It's not always possible to predict which ones are going to be worse, but in this single-centre study by Sanders et al., the combination of busulfan and cyclophosphamide, for example, was even worse than total body irradiation. There were no pregnancies in women after this combination. In contrast, other combinations like beam, carmustine, etoposide, cytosine, and melphalan, in comparison, it's almost like a fertility drug. You can see there's been large numbers of pregnancies in studies which have evaluated it. And this study is particularly interesting from Saudi Arabia because unusually they knew how many patients were trying to get pregnant in this study. And of 40 patients who were trying to get pregnant, 26 succeeded. In general, the patients who do succeed in getting pregnant after these protocols are young at the time of transplant, as you might expect, because they are going to have more eggs and they start off. This is to highlight the fact that we really don't have enough data about these protocols. There have definitely been some pregnancies after being in men, and yet to autoimmune diseases, we can see there's a huge variety in outcomes. We can't assume that in low doses of drugs and use, everything's going to be okay. We have to look at what the results are. So actually, for cyclo-ATG, just a couple of tiny follow-up studies have suggested that gonadal recovery is possible, whereas fludarabine, busulfan, and ATG, there were no recoveries at all in this study. So we know that young women, possibly young men, are more likely to retain fertility. Some drugs are less gonadal-toxic than others, and some combinations of drugs are better than others. And there's also no doubt that patients who have access to assisted conception are more likely to have pregnancies after transplant, and so in that sense retain their fertility. In our most recent EBMT data that's just been presented in abstract form at ASH last year, it was notable that of patients who talked about the method of conception, a third of female patients had used assisted conception techniques, most common one being use of donor eggs, and 55% of males had used stored sperm in order to get pregnant. So it really is very important that transplanted patients have access to these techniques. Now there are many guidelines on both sides of the Atlantic that cover this topic. I'd recommend that men have sperm stored and that female patients should be offered embryo or egg storage. But notably, a lot of these do refer to patients having gonadal-toxic treatment in the context of cancer treatment. In this guideline and this one here, the words cancer are in the title. The NICE guideline in the UK doesn't have cancer in the title, but if you read the guideline, it refers to patients having sterilising treatments in the context of cancer treatment. This guideline is actually, in its previous iteration in 2005, it did have the word cancer in it, but it's specifically taken it out, and it refers to gonadal-toxic treatments. The reason this is so important is, particularly for patients with autoimmune diseases, it can be difficult to get access to these techniques unless insurance companies cover it in certain parts of Europe and across the world, and it's important that it's endorsed in our guidelines. So, what are the special considerations of autoimmune disease in patients who want to get pregnant? Well, there may be issues related to the ability to conceive, contraindications to pregnancy, sexual dysfunction, different wishes to have children, and then there's the effect of pregnancy and the underlying disease, monitoring the disease of pregnancy and postpartum. And really this all takes into account the point that's already been made very well today, that just because someone's had a transplant, it doesn't mean they're inevitably going to be cured of the underlying disease. 30 to 40% of the patients probably are going to relapse and have some evidence of the disease when they are then thinking about developing pregnancy. We also need to think what treatments that the patients had before the transplant that may be gonadal-toxic, and which conditioning protocols are we using. And if we look at some of the data from John, who updated the data in 2019, we can see that the three most common autoimmune diseases that are being transplanted overall now are multiple sclerosis, systemic sclerosis, and inflammatory bowel diseases, Crohn's being the highest one on that list. And so I'm just going to briefly talk about issues relating to those three conditions. So multiple sclerosis doesn't appear to have an effect on fertility, but it does have an effect on sexual function, erectile dysfunction, spasticity is important, and it can also, there's also some evidence that the drugs used for assisted conception can increase the risk of relapse. Apparently the risk of relapse falls overall during pregnancy, but other issues can be important, such as urinary tract infections, which are common in pregnancy, can actually cause deterioration in symptoms of multiple sclerosis, and spasticity or lack of awareness, lack of sensation during labour can also be problematic. And although the risk of relapse isn't increased during pregnancy, it is increased in the first few months postpartum. Systemic sclerosis also has a constellation of issues that are relevant to pregnancy. Again, sexual dysfunction is common. This may be physical and emotional, and in fact pregnancy may be contraindicated in patients potential disasters relating to pregnancy. Firstly, I'd like to point out that there is actually an increase in voluntary childlessness in patients with Crohn's disease. And although fertility can be normal in patients with Hsct disease, in many patients it isn't. If they've had any surgery or disease of the terminal iron, there may be scarring to the fallopian tubes. Sulfasalazine leads to reduced sperm counts, although of course that is reversible. But rectal surgery may lead to impotence, ejaculatory problems, and of course a transplant isn't going to change any of these anatomical issues. The risk of flaring during pregnancy is altered in Crohn's disease, but there is a 34% risk of flare a year. So approximately a third of patients will actually have a flare during pregnancy. And what that means is it really increases the risks of the baby. It increases, you're likely to get a premature or a small for gestational age baby anyway, but if the mother has a flare during pregnancy, you're going to have an increase of fetal loss, stillbirth, and developmental defects. So these are all pretty concerning features. What about gonadal-toxic treatments before transplant? Well, we've mentioned that cyclophosphamide, of course, is an alkylating agent. It is gonadal-toxic, and there's no doubt that patients can have gonadal-toxic and actually sterilising doses of cyclophosphamide before they ever come to transplant. In this single-centre study, actually from this very city, Berlin, Mazenkar describes 15 patients who were transplanted for autoimmune disease, and the median cyclophosphamide dose before transplant was 9.4 grams. Now, 9.4 grams, you can see on this was actually a study back in 1977 of patients receiving cyclophosphamide for breast cancer. But you can see you only need 5 grams as a cumulative dose to sterilise everyone over the age of 40 and most people over the age of 30. And that was only the median dose in that last study. If you received a cumulative dose of 30 grams, that would be more than enough to sterilise a girl of 20. So what about conditioning protocols? Well, we've already heard a lot about this today. Just broad brushstrokes about conditioning protocols. You can divide them into, of course, the high intensity, the intermediate intensity, and the low intensity protocols. High intensity ones, infertility is extremely likely unless you're using assisted conception. Intermediate intensity fertility is possible, as we discussed, because this includes combination chemotherapy such as beam. And for low intensity, well, really, it very much does depend on the protocol that you're using. This is just a slide by Moraro, who looked at the regimens, who summarised some of the regimens used for multiple sclerosis. This was a long-term follow-up study of patients who were transplanted for multiple sclerosis. So these data are going back to 1995 to 2006, so quite a long time ago, but they do highlight the difference across the Atlantic in the protocols that were being used, with perhaps more high-intensity and low-intensity ones in the USA compared to intermediate intensity ones in the EBMT. And it's very nice from a fertility point of view to see the preponderance of transplants that have used agents such as beam. So what data actually exist? There's been one large study that's looked at, done by the EBMT, which looked at databases from the EBMT and also Sao Paulo in Brazil. And they looked at 324 women of potentially childbearing age who were transplanted. And the median follow-up was 6 years. In this study, there were 15 patients who were pregnant, so this gave an instance of approximately 5%. But not surprisingly, the median age of transplant of these patients was low, it was 28, range of 17 to 32. And of these pregnancies, 32% of them failed. There were 4 spontaneous miscarriages, an ectopic pregnancy, and a fetal death, and exacerbation And really, it very much mirrors what we know in terms of how many patients have been transplanted for different conditions. So most pregnancies have occurred after multiple sclerosis or else systemic sclerosis. It's nice to see that assisted conception has been used in a few of these, but just the odd case in each series, perhaps not as many cases as you might expect. And in terms of the outcomes of pregnancies, really the immunne study by Hsct and colleagues, I have to admire the fact that they did get extremely good data, including these unsuccessful pregnancies and pregnancies with complications. In the other studies, there's often a tendency only to pick up successful pregnancies. So in summary, maintenance of fertility in pregnancy is possible, particularly in young patients following transplant from autoimmune diseases, depending on pre-transplant treatment, conditioning protocols used, and whether or not the disease is well controlled after the transplant. But I just ask everyone to consider perhaps psychology of embarking on parenthood in these patients may be very different to those who have malignant disease, which is potentially curable. And I think it's very interesting that in Crohn's disease there is an increase in voluntary childlessness. The second thing to consider is there's access to assisted reproductive techniques in patients who don't have cancer. And it's imperative that these patients do get the same sort of access. And the third point is that I don't want anyone to think that we have all the answers where these protocols are concerned. Particularly for reduced intensity protocols, the data that's available on gonadal recovery is really small. And I would urge everyone to collect this data on the trials that they're conducting. So thank you.
First, on my Aidwp-based. What is the current recommendation for those patients before they go to transplant?
Well, I don't think there are any recommendations, to be honest. I think any patient that undergoes a transplant has to, should have exactly the same preparation as somebody going to a transplant for malignant disease. Potentially, it's easier for autoimmune diseases because you don't have to leap in and transplant them within a week. You can't wait to stimulate the ovaries or collect sperm. So I think there's no excuse for not doing it. It's just this concern about our existing guidelines being so orientated around malignant diseases. But I think everyone should have sperm, every man should have sperm stored, and every woman should have eggs or embryos stored if they want them. But of course it might be that some of these patients don't want them. I made a comment right at the start that we'd imagine it's a big issue in these patients because they're women of childbearing age. But they're also women of childbearing age who've got completely dreadful diseases, and I wouldn't be, it would not be a surprise if a lot of them didn't want to have children.
Very nice presentation. I have two comments. One, it's true we did a study on women after the transplantation. Most of them didn't want to have children afterwards, so that really the chances of having children if the women wanted are much higher than the studies show, probably. The second comment is to the pregnancy loss, especially in patients who have systemic sclerosis. We have to remember about the antiphospholipid antibodies. So if you have pregnancies in those women, we should, especially maybe if they consider pregnancies, maybe we should test them for antiphospholipid antibodies and prevent some of these pregnancy losses. This is a topic which is not, I think no studies in our patients sort of address this, but it would be quite interesting also to see.
I think this would be very interesting. I mean, it was quoted that there were 4 miscarriages. But the thing is, the baseline rate of miscarriage is actually very high, so it's not possible in a small sample like this to know whether it's increased above the baseline population, particularly when you're going, it was your study in fact, when you were very thorough in your data collection. We often don't get much data on miscarriage, so it could be that it's not increased, but you're absolutely right, we should be collecting that sort of information.
So quick question, quick answer please.
Really interesting topic. Just on the washout,
least 3 months, because that's how long the follicles take to develop the vitamin-exposed therapy. But this is very theoretical, and it's not really based on data.
Last question, please, by Renata Arnold.
I would like to make a short comment to the Berlin patients, because they were from us. And they became pregnant. They were at this time all in remission, and they were young women. So this was a high number of pregnancies successfully. In our group with acute leukemias, and we have about more than 1,000 allogeneic transplants in acute leukemias, the people didn't want to have children afterwards. We had only one young woman who was irradiated with 10 gray, and she was 16. She later became 2 children. The others didn't want.
And did you actually formally ask, do a survey to see if it was
Yes, because we have not only a survey, it makes a follow-up in our clinic, so we know the patients. And
that's really very
in our patient ward.
Thank you very much, Nina. I would like to close the session